With us will be presenting on implementing stewardship in community hospital and resource limited settings. So Dr. Johnicker is the pharmacy clinical coordinator at Northwestern Medicine Kishwaukee Hospital in DeKalb. He earned his Doctor of Pharmacy from Butler University in Indianapolis in 2006. And after working in the Department of Pharmacology at the University of Colorado at Denver, he began his pharmacy career in 2009 as a clinical staff pharmacist at Fayette Regional Health System in Connersville, Indiana. He then moved in 2012 to become the Director of Pharmacy at Putnam County Hospital, a critical access hospital in Greencastle, Indiana. Following relocation to Chicago in 2015, Dr. Johnicker assumed the role of clinical pharmacy manager for the pharmacy department at South Shore Hospital. Including his current position, Dr. Johnicker has overseen the implementation and improvement of stewardship programs at 3 different community hospital settings. He recognizes antimicrobial stewardship as an exciting area where pharmacy is poised to have a great impact on patient care, and he has enjoyed the challenges that come from small community hospital pharmacy and the demand to wear and have. So welcome, Kyle Johnicker. We're so excited to have you, and we hope you all enjoyed this presentation.
All right, excellent. Thank you very much. I do believe we are in a small enough room, and I have been accused much more often of having too loud of a voice than too quiet of a voice. So if anyone can't ever hear, just wave like crazy, and I will assume not a seizure, but that you can. Thank you for spending your post-lunch work-through period here in this nice, dim, very nappy kind of room. So try to, if possible, stay awake or keep your snores to the middle, whichever way it does work out for you. And so some of our objectives today are to discuss the important first steps in development of an antimicrobial stewardship program in the community hospital. We'll also look at the challenges to antimicrobial stewardship in that setting, and then work towards some tools and strategies to overcome those challenges. Just for point of clarification, when I think community hospital, I think the smaller, the more rural, the non-academic teaching institution. If you look out there for definitions, it is very, very varied, but that is what I have in mind. So even though I'm part of Northwestern Medicine, I am not at the flagship downtown spot where they have lots of extra resources, lots of specialization. So just kind of record setting on what we're looking for there. So this is the one and only slide in which I will claim to be an expert. That is the About Me section. See, a lot of it was kind of given away on where I have been, but really this is my opportunity to sell you on, I have worked in community hospital and have seen what this is like. So I did graduate from Butler University. And then when I staffed at Fayette Regional Health System, it was a 70-bed facility in a small town of about 14,000 over close to the Ohio-Indiana border. Cincinnati was our closest big city, about an hour and a half away. Then I moved to be the Director of Pharmacy at Putnam County Hospital, a critical access facility in Greencastle. Greencastle, about 10,000 people in that small community, about an hour outside of Indianapolis to the west. Then personal reasons, moved out to Chicago. So now big city, yes, not out of the community hospital, but no, South Shore Hospital is a community facility, about 130 beds on the south side of town. And so I think it's good to name that community hospitals and resource limited facilities are not just meaning that you live in the country. And so heart of Chicago and still definitely a resource limited facility. Then did some moonlighting at Humboldt Park. So yet another in the city, urban hospital, about 180 beds, 200 beds, but similar situation on as far as being under resourced. And then out to my current position, clinical coordinator with Northwestern Medicine Kishwaukee Hospital in DeKalb. So for those who are either way downstate or way in the city, DeKalb is kind of in between those two things, still northern, about 2 hours away from here, but 60,000 or so people between Sycamore and DeKalb proper. So a little bit more of a town than some of the places I have been, but still definitely a community hospital, 98 beds, always looking for more resources to do more on how we can implement the stewardship program. So hopefully you're now convinced that I have seen 1 or 2 things in the community setting, and then you can try to believe me the rest of the talk. All right, so what I do want to know is about you. And so just by show of hands, who here is at a critical access or 25 bed or less facility? Good mix, excellent. Next step up, 26 to 100 beds. Okay, a few more, that 100 to 300 range. Good mix. And then who's at our big places? My Northwestern medicine friends. Excellent. Very good. So that's a good mix. A lot of critical access. I think you guys actually won from the largest percentage. So definitely a struggle to get all of that done. All right. So next question for the group. Current antimicrobial administration or antimicrobial stewardship program. Who would say they have a well-organized and efficiently ran program? Hands up, because everybody else look around. These are the hands of the people you need to talk to after this conversation. Because we'll talk later, but networking are 3 ways to improve a under-resourced program. So those who raise their hand as an efficiently well-run program are who you want to talk to. All right, who has a program that they feel like is just getting started? All right, much bigger group. Who does not have the official program? We're doing some of the work anyway. All right, 1, very good. And who here says, I hear antimicrobial stewardship is important? All right, good. That's excellent. I'm very glad that nobody says I have no idea what's going on. All right, one last poll, not quite on the screen. Who here is ready for an engaging conversation around antimicrobial stewardship led by an outstanding speaker? All right, well, if so, I do recommend in about an hour we go to Jamie Borkowski in a different room on the beginner track. But I will do my best to get you through it. So really, let's start with what do you have to do for an antimicrobial stewardship program? The good news here is I don't have to make up things. The CDC tells us what we have to do. I'm sure everybody in this room then has seen these. Everybody has worked through these. And there's really nothing special for me to add. These are the elements you have to put into place to start and run an antimicrobial stewardship program. And so just say those expectations. I don't have to recreate this. Recently, though, our friends at the Joint Commission said, CDC, you have 7 elements. Let's raise it to 9 elements and 12 different pieces inside of those elements. Because it wasn't hard enough when the CDC alone was telling us what to do. We now have the Joint Commission trying to tell us what to do. And everybody knows that's a fun thing to work here all together. The good news is, as we look at these, they really do align very closely with what's already in place at the CDC level. In fact, we'll talk in a second, but you get to use the fact that the Joint Commission wants us to do this as one of your tools and strategies to help expand your program. So there it is, first steps, right out of the gate. Engage hospital leadership, follow the playbooks and the programs that are put out there by Joint Commission and CDC, put your committee together, and you're off and running. All right, so what are we gonna do for the next 40 minutes? We're good, right? We have it, program's ready to go. I don't see a lot of head nodding. So I assume I have a little more work to do to walk through the fact that there are challenges to building this antimicrobial stewardship program. And in fact, we should start with, is it a hard concept? And I would argue absolutely not. The right drug at the right dose by the right route for the right amount of time to improve patient outcomes, decrease resistance, is not a conceptually hard concept, right? Are you going to find a single provider that you talk to that says, oh no, we should use the wrong drug at the wrong dose for way too long, and I hope it doesn't go well for the patient, right? Anyone ever says that, then you go talk to your CMO really, really, really quick. So conceptually, antimicrobial stewardship is not hard. In practice, it is incredibly difficult. You're fighting a whole bunch of different things. You have physician experience, you're having physician training, you're having logistics. Who gets to do the work? What work do we have to put in place? What technology do we have to do? And all of a sudden, it's an overwhelming amount of things that we have to get going very fresh. And every core element and regulatory standard has challenges that we have to go through. So here they are side by side, CDC core elements, the Joint Commission recommendation. So again, 7 versus 9. But really they kind of line up, right? Hospital leadership versus organizational support, same thing. So we kind of group those together. And then my question here is going to be, what is most important in an antimicrobial stewardship program? So show of hands, hospital leadership or organizational support. Who thinks that is the most important piece of a program? Couple, very good. So accountability or program leadership, multidisciplinary committee. Who thinks that's the most important? All right, pharmacy expertise kind of also fits right in there with program coordination and multidisciplinary committee. Oh, I'm hurt. As a pharmacist, no one thinks we're the most important part. My world is shattered. I'll get over it though. So action and actually doing then, monitoring use, optimizing prescribing, implementing guidelines. Who thinks that's the most important? Okay, very good. Reporting, data collection and reporting. Sending all that info to the CDC. Yeah, not a lot of fun in that one. Education and performance improvement, kind of separate ideas, but education, who thinks that's the most important part? Yes, your hand's very good. All right, so I'm not gonna lie to you, it's a trick question. It's a chicken or egg question, right? Because if you don't do one of these pieces, they directly interact and overlap with the other. In fact, the Venn diagram would basically be one giant circle that they all fall under there. Because if you don't educate, you can't do, right? And if you're not doing, you don't have a program. You don't have leadership support, how do you have the people to do the work? And so one on top of another, there is no real good one spot that you have to tackle to do all of it, which is frustrating when we're trying to say, how can I make this work when I don't have anybody to do the work? But it's important to recognize that that is the challenge for all hospitals, regardless of size and regardless of resources. So this is for everybody that we're having this type of struggle. But we're here to talk about the community hospital. So what do we have to do? I think the first thing to remind yourself of is you're not going to do it right away. There is no snapping a finger and suddenly you have a well-run antimicrobial stewardship program. So Percy Cerruti, an Australian coach, an athletics trainer, said hard things take time to do. Impossible things take a little bit longer. But what I love about this quote is even the impossible is doable, right? This is not a, you can't overcome this. You can get it done. But really the question then is, who has the time? Because you have to do the pieces, you have to do the work. And so if you're at sites like all of the places I have worked, lack of dedicated resources. So in the pharmacy department, never worked in a spot where we had someone whose sole job was to focus on antimicrobial stewardship. It's kind of the dream, but we're not there at all these community hospitals. We also have other service lines that also don't have dedicated time with the billing. So especially the critical access facility, if you have an oncology program at all, your inpatient pharmacy is probably also your oncology pharmacy. And if you have a busy oncology center, they're doing that a lot. And those take time to mix, to double check doses, to get ready. You might also be in a small community where your inpatient pharmacy is also your community anticoagulation service. And that takes time to assess and to call and to check. You don't have dedicated service lines to each of those on the pharmacy, especially. Competing priorities. How do you value antimicrobial stewardship? And the more important question is, how does your facility value antimicrobial stewardship? Because you, as a person, could say, this is the most important task we have to take on. You alone can't make that change. You have to have consensus and some building going on. And then the other departments in your facility will also have priorities. And speaking as a pharmacist, if that priority involves medications in any way, shape, or form, the pharmacy department is coming along for that ride. And now we're focusing on that. And it's more time that we don't get to spend on antimicrobial stewardship. And so some examples are lots of stuff about decreasing readmissions, discharge counseling. Where can pharmacy make sure that guideline therapy is prescribed at discharge? Very valuable, not trying to discount that in any way, shape, or form, but it takes time. You're going to do a really good discharge reconciliation. That's 30 minutes at a minimum, where you're going to review the chart, review the notes, check the disease states, check the guidelines, and make sure everything is ordered correctly. Not even crossing the bridge of, well, insurance paid for it, only send that prescription out the door. will my local retail pharmacy, which only has 8 hours a day of open time, unless it's the weekend, then it might be 4, are they going to have it to fill it? So these are all issues and concerns that people have while we're trying to add an antimicrobial stewardship program. Technology optimization. Your EHR needs work. You have to add new drugs. You have to build order sets. You have to check the labs, make sure things are flowing. Again, most community facilities, resource limited facilities, do not have an informaticist, let alone a pharmacy informaticist, let alone an antimicrobial stewardship informaticist. I know that's even one of our asks for our big system here at Northwestern Medicine. We would love to have that level of dedicated resource, and we still don't have that. And then automated dispensing cabinets, while great, I think, is there anyone in the room who has not had to babysit a technician coming out to fix an ADC for a little while? And while you're sitting there, maybe with a laptop, maybe not, to do work, twiddling your thumbs, watching them put a new drawer in, time you're not doing pharmacy work, it's time you're not doing antimicrobial. And then there's attending committee meetings. And so there's no denying the value of frontline staff, nursing staff, provider staff, pharmacy staff, to be at the front line of those meetings. Otherwise, you get decisions made without that input, and that's poor. But again, committee meetings take time. They pull you away, and you're not focusing on the day-to-day boots on the ground of antimicrobial stewardship. And all of this leads you to feeling like maybe you're wearing too many hats and asking for a friend. How many is too many? And so I love this cartoon because one of the things I've always told my pharmacy students about my career and where I currently work is I love wearing the different hats. I think it's actually one of the strengths of the community hospital and community hospital pharmacists is you get to be oncology, you get to be IT, you get to be cardiology. However, you can get stretched too thin. There's just not enough time in the day to invest in all of those things around the clock. And so that's the struggle we're going to run into is how do we get through that piece? And there was personnel issues. So you have your staff. You have how many you have what shifts you work, you have how many hours those are. These are the starting pieces. I don't know if anybody in here plays board games. My brother loves board games. But the first thing you always do is you find out what do we have to lay out? What are our pieces on the board? What cards do people start with? That's what you're at right now. That is who you currently have employed and what hours they are working. That is the starting piece of this board game known as antimicrobial stewardship. As the game progresses, you'll move pieces around. You'll get new resources. Sometimes you'll lose resources, but we have to navigate through all of that. So make sure you're assessing what you're working with, because the answer to implementing antimicrobial stewardship is not just throw more FTEs and throw more money my way. It'd be great, it would help, but it's not the answer. You still have to put the program. So you juggled your workflow, you found the time. Congratulations, antimicrobial stewardship, here we come. But do you have the right person at that spot? Do they have the education or training to do it? If they don't, is the time or money available to provide that? And even through all of that, do they now have the confidence to step into that role? It can be nerve-wracking, especially if you're young, to go up against a physician right out of the gate and say, you know, doc, that's the wrong drug. Don't ever say. But you have to have the confidence to at least think that and then support it and back it up with your facts, your evidence, and your data, all of which comes through experience and training and education. And so even when you find the time, there's still one more. I feel like I'm preaching to the choir at this point. Everyone's on my team that these are the challenges. But we're not done yet, right? There's still more challenges. Infectious disease providers. As you're at small, rural, tiny facilities, so how many of my critical access hospitals have an infectious disease trained provider either on staff or on consult that sees patients in their facility? 1, 2. Wow, very good. I'm very happy for you two. And the expectation of the other 10 of you is what I'm used to. And that is, it's hard. And it's hard really even at multiple sizes. And so even when you have them, how available are they? Are they seeing other patients at other hospitals? Do they have their own clinic hours? Do they round maybe for 30 minutes once a day? Do they respond to pages and texts? I see some head shaking because we've all lived in that world too. Are they a hospital employee or are they consultants and available on contract? So the question here really is, who foots the bill? Who's paying them? Because that drastically can drive motivation on, are you going to listen to what we're doing when the hospital says you need to do this? If your marching orders don't come from the hospital, harder to get that done. Recruitment. If you live downstate in the middle of nowhere, Illinois, hard to get an infectious disease provider to say, that's the town I want to live in. I also oversee work with Valley West Hospital in Sandwich, Illinois. Very few people are choosing to live in Sandwich, Illinois, including infectious disease consultants we see at Kish. They're available on phone, but they don't live down in Sandwich. And so it's tough, and that is outside of many of our purviews, but something that we get to talk about with C-suite, right? We need the resource, we need the doctor. And similar to that pharmacist question and other staff, if you don't have any ID trained providers, how can you make the providers that you do have receive some ID training? Is there time? Is there money? Is there education? Is there confidence in stepping into that space? And then how do we make that available to those providers? All right, one more limitation, then I'll move on to something slightly better than all of these sad challenges. And that's the technology. What EHR are you using? What electronic health record? Does it have ASP bells and whistles? So the first two hospitals I worked at in my career use CPSI as an EHR. I don't know if anyone has ever seen that one before. I see a couple head nodding. A bell and whistle for CPSI was a keyboard shortcut. And we laugh, but it is honestly goodness true. You could see nothing on any one screen. You had to back out and go to a whole new screen if you wanted to check any new information. This was not conducive to trying to find out at verification, what might they have? What's the note going to look like? What labs do they have? Moved on to facilities with Meditech and thought, oh my gosh, I've stepped into a whole new world. Things are available. I can see stuff. And now with Northwestern Medicine, we have Idph. And Idph is an absolute beast of everything you might want it to be if you take the time and have the people to build it the right way for you. So even when you think you step into the promised land of having all of the bells and whistles you might want, you don't have it set up correctly or optimized for you, it's really not going to help your life as much as you might want. Still better than CPSI. But then clinical decision support. Does your EHR provide information to the ordering provider, to the verifying pharmacist, to the administering nurse? Can they see that during that workflow? Or is it a separate step in a manual process to go track it down? And then reporting, while the least sexy of all of the fun elements that we have to talk about, is necessary. And so does your EHR have the ability for reports and to put things together for you? The other technology that is tied directly into a good antimicrobial stewardship program is going to be what your lab can provide. So can you run, I picked procalcitonin here just for fun as an in-house lab, but can you run those necessary diagnostic tests in-house? Is that information that will be available to you in the next 15, 30 minutes, 60 minutes? Or are you sending it out to 2 towns over and you might see it in 4 to 6 hours, most likely the next day? At which point, is our rapid diagnostic testing really very rapid, if that's the case that we're looking for? And so you cannot separate good antimicrobial stewardship away from your diagnostic point and what the lab can provide. All right, so now for the hopefully more encouraging pieces, and that is, how can we overcome many of these challenges that was just laid out? Well, we'll go ahead and start at the top with the hospital leadership committee. And if the regulatory requirement is not enough to get hospital leadership on your team, how else can we convince them? So you have to talk into terms that the C-suite will understand. And before I go further, any C-suite people in this room? All right, don't see any. Very good. So we have to talk on their level, which is real money and real time. right? I've never once convinced anyone in the C-suite with cost avoidance or soft dollars or fake dollars or whatever monies that doesn't actually ever hit a real budget, right? It sounds good, it looks great, but they're never going to approve anything on cost avoidance. So we really do have to look at hard dollar savings and what are areas that antimicrobial stewardship can truly save us. Lots and lots of literature out there to really cover these three areas, but an impact on length of stay. And so this was an interesting study that they looked at accepted interventions versus rejected interventions. And they matched the patients and what they were here for. Accepted interventions had a half-day shorter length of stay. So by listening to the intervention for antimicrobial stewardship, patients were out the door faster. What's really interesting is 2 days less on days of therapy. So even though there's a small impact on length of stay, we stopped antibiotics quicker. I say we, I was not involved at all in the study, it's just a conversational thing. But 2 days shorter in that days of therapy, which to the surprise of no one in the room, antibiotics are not the only reason people are in the hospital, right? Like they're there for other stuff and that can impact their length of stay. And most importantly, no impact on readmissions as far as increasing them. So we got them out the door, we got them off antibiotics, and they didn't come back at a higher rate than those who had the accepted intervention. Can we decrease readmissions? That's a holy grail. I think there's some evidence that it can, but readmissions are just very, very complicated, very multifactorial, and antimicrobial stewardship alone is not enough to truly drastically impact readmission, but is a piece. And here's the one where, from a pharmacy perspective, especially, and antimicrobial stewardship on the whole can make some big changes on it. Decreasing your drug spend. And this is hard dollars. This is real money you are not spending. There was a study from the Ohio State University, Wexner Medical Center, not by any means a small community hospital. I think their budget was somewhere in the $25 million+ on antimicrobials and all kinds of craziness, 1,200 beds. But by focusing on this low-hanging fruit that we'll cover in just a slide or two, $30,000 of real drug savings. So again, scalable to your size facility, but this is real money not spent by the facility on drugs because of low-hanging fruit. So also talking to the C-suite, evidence is great. Go in with a stack of papers and say, hey, here's all the literature, here's all the evidence-based guidelines. Some C-suite executives might be convinced by that. Most will not. What the evidence can do for you, though, is get you a pilot program, get you support to start small and try something. And then it's up to you to make that part successful. But that's your foot in the door sometimes. It is, how about we try it in this week? How about we try it for this month? How about we try it for this particular person? Maybe you have that one physician champion. We're going to try it with Dr. Smith. He's on board. And then you collect your data, and now you have another argument to be made. And so this review article talking about the value of antimicrobial stewardship really is the way to sell antimicrobial stewardship back to your C-suite. Again, value is better outcomes over lower costs. So we're helping patients. They're out here quicker. We're treating their infection with less drug. We're not impacting readmission. We're lowering hospital costs, decreasing length of stay, spending less money on drugs. And antimicrobials, less drugs, less resistance. All of these things are good. So our value comes from saying we improve your outcomes and we lower your costs. So good review article, covered a lot of different of the studies and articles that are out there about which things might help lower your cost and improve your patient outcomes. But really, this is your elevator pitch, right? This is, I have 30 seconds to tell you what antimicrobial stewardship can do. We have value because we improve outcomes and lower costs. I didn't need 30 seconds, right? 10. Moving on. Now, fund my program and let's get going. All right, so really, here's the strategy. Don't reinvent the wheel. We're at a summit for antimicrobial stewardship. You saw a handful of people raise their hands and they have a well-run and efficient program. You do not have to start from scratch. You are not the first person to run through that brick wall. They are out there. You got to find them. So discuss visit, critique, evaluate. Here's the thing about antimicrobial stewardship pharmacists. I have not met one who is not willing to sit down and talk to you about all the cool things that they have done in their career. And those are things that you can then apply at your own local setting. So ask, hey, what is it you're doing? What are you most proud of? What was the most recent initiative you started? And listen and take it in. And I'm going to plug Northwestern Medicine here, adsp.nm.org. This is a public-facing website that has all of the resources that Northwestern Medicine uses on a daily basis for all of our patients. So adsp.nm.org. I will say it at least one more time later in this presentation. But find programs that have been successful. Talk to those pharmacists. Talk to those physicians. Do the old Google search and look at all of the different programs that also share websites or things similar where they put their resources out there. You do not have to be the first person to write a protocol. It exists. So guidelines and recommendations. We love evidence-based medicine. We love evidence-based guidelines for disease state treatments. Why would we not also love evidence-based guidelines for programs? We should, and they already exist. So we're going to talk more about the core elements for resource-limited settings here in a minute. The executive summary from the IDSA and SHEA is very, very good and lays out some areas that they say, not worth your time. Sounds great, doesn't have actual impact. And so that's a good place to start. And really, I could have saved myself a lot of time and just handed everybody the National Quality Form antibiotic playbook when we walked in, and then we just could have read it for an hour. Because it lays out the beginner track, intermediate track, and advanced track for all of the core elements that exist, the challenges you might face, and ways to overcome. So if you haven't looked at that resource, go ahead and track that one down, find out where you're at, and what things might be implementable and what areas to come. And so here's an important quote, and it's hard for me to read the name here. So from Marion Wright Edelman, we must not, in trying to think about how we can make a big difference, ignore the small daily differences, which can make, over time, add up to the big differences we often cannot foresee. So the key here, small daily differences over time add up to the big difference. Again, you don't have to take on the entire program at once. Start small. Start small and focus on what you have and what you can implement. So look at those few small pieces. So that low-hanging fruits article from the Ohio State University. Here are the 4 things that they did. These were the only 4 pieces that they implemented or looked at, and they saved $830,000. Idph, therapeutic substitution, batching antimicrobials, and formulary restriction. My guess is the pharmacy department at every one of your facilities is already doing these things in some way, shape, or form. Idph is as I think earlier we heard, established for over 30 years now. And I have not worked in a hospital we did do some level of Idph. However, we always like to put extra restrictions on doing antimicrobials. 48 hours fever-free, not a resistant organism, so on and so forth, right? So because the program already exists, the protocol already exists, all you have to do is explain. You're not starting over. Idph is already in your hospital. Make antimicrobials show up on there too. Therapeutic substitution. Not a hospital in the country not doing therapeutic substitutions. We don't carry every PPI. We don't carry every ACE inhibitor. Carry one. Yeah, again, antimicrobial, sometimes it's everything. Sure, have moxifloxacin, have levofloxacin, have ciprofloxacin. You don't need all of them. You don't need every beta-lactam that's ever existed. Where do you have opportunities to narrow your formulary and at the same time encourage the use of those either cheaper or equally efficacious or better tolerated medications? Batching of IV antimicrobials, and I kind of added on here standardized administration time. These are ways to decrease waste. And so the study from Ohio State, they started batching their daptomycin. because there was lots of waste the way it comes, 500 milligrams, but then weight-based. Somehow now you have to break into a whole second vial just for a little bit. That's when it's expired before the medication, blah, blah, blah. So by standardized administration times, they batched when they make all of their daptomycins, and they were able to maximize their spend. Even if you're a small facility and might only have one patient on dapto, there's other opportunities here. So by batching things that you make, you save your technician time on the pharmacy side, and you can make sure that things are being standardized and when they're given. That also gives you time to assess whether something's appropriate or not. If the drug is given at 6 a.m. every day, you don't have a pharmacist even in the building. You have to take a look at that medication with labs, that opportunity. If, however, you're like, we're not giving them back till 10, maybe 11. Now you have an opportunity to assess how are they looking that morning. Do we have a de-escalation opportunity today as opposed to waiting another 24 hours? So have to work with your nursing leaders on standardizing administration times because that has to work with nursing workflow. Formulary restriction. Pharmacies have P&T committees. Not every drug out there is on your formulary. Not every drug is available. So where do you have opportunities to restrict? Whether that is not available at all or whether that is specific criteria that must be met. What I love about batching IV antimicrobials and formulary restriction, those are relatively inside pharmacy control. So small hospital P&Ts, in my experience, pretty much can get what you want approved. You have the conversation before you go there, you lay out the evidence. At the actual meeting, mostly rubber stamp. You've already done the legwork. And once it's rubber stamped at P&T, it's now official hospital policy. And you get to stick to it and get to hold of physicians accountable to within your own control, which is great. One more thing I tacked on here, just so my pharmacist card does not get revoked, vancomycin dosing should live within pharmacy control. It is more than just looking at levels and looking at renal function. When pharmacists get an opportunity to look at vancomycin and dose all vancomycins, the first thing they should be asking isn't, oh, what dose do I want? It is, do I even need it? And then by asking that question first, you have an opportunity to also look at the infectious disease status of the patient as a whole and do good antimicrobial stewardship on those patients. And so by taking that into a pharmacist control, there's the opportunity to improve some of that care. All right, so some other pieces of starting small. This was a study done at 47 hospitals in South Africa. So this is an example of nationwide antimicrobial stewardship. So the country of South Africa said, we're not doing a good job. We can do better. And they implemented 5 things at 47 hospitals across the entire country. Those 5 things: culture's not done before we started antibiotics, more than 7 days of treatment, more than 14 days of treatment, more than 4 antibiotics at the same time, and concurrent double or redundant antibiotic coverage. My guess is everyone in the room sees those 5 things and just wants to give a little face palm, right? There's not a single thing on that list that makes you go, why has this not been done before? Who's not looking at these things before? So I would argue that this is very low-hanging fruit to be able to make sure cultures are done. In fact, we have to do that for sepsis anyway. 7-day check, 14-day check, 4 antibiotics, and very few conditions that would ever require 4 antibiotics, and then that double coverage. The other piece that was really interesting about this study is, like many of our facilities, IV trained staff, pharmacists specifically got to call out, but even providers, are not present at the 47 hospitals across South Africa. So they had this comment that said, in this scenario, we should not underestimate the role of the non-infectious disease pharmacist in promoting interdisciplinary engagement stewardship programs in hospitals across health systems. You don't have to be IV trained to have an impact. And it's very important to take back to our limited resource facilities. Here's what this study showed. So we're looking at the defined daily dose. Kind of that first column on the side is the baseline period, the ramp up period, before they talked about it at all. Middle section is during the implementation, and this back section here is after they implement. So defined daily dose per 100 days, they started right around 100. After implementing, they maintained right around 85. 15% or so decrease that was then maintained without IV trained staff by focusing on 5 things that we probably all agree should already be done. All right, so I told you we're going to circle back to the CDC core elements. So they have the small and rural hospital critical access facility guide, which is very, very good. I'm not sure how many in this room have actually looked at the resource limited guide. All right, not surprising. When I first pull it up, you read the first section, it talks about this national antimicrobial stewardship when you're a resource limited country. Most of us don't consider the United States a resource limited. And so you read that first paragraph of this guide and you're like, oh, that's not for me. That's the developing world. That's these other countries. There's a whole section though about hospital level resource limited. That applies to us in this room and applies to us in the United States. And so it focuses on a stepwise approach. So 1, 2, 3, you start here. Form your committee. Again, give another plug to my colleague, Jamie Rakowski, going to talk about the committee building and who you need to have on your antimicrobial stewardship team the next hour. But in this, pick a single priority. So what we've been talking about, start small. Don't try to cover all 7. So focus only on one priority area. If you can, make that a data-driven priority. Are you overusing meropenem and zosine? Great, let's take a look at that. Are you using drugs for too long? Duration of therapy a problem? Great, let's focus on that. I see lots of head nods. Remember, pick one. Don't overstretch yourself. But look at your data. What does it tell you? Do we have which drug we're using problem? Do we have a duration problem? Which one needs to be our focus? Don't overshoot. If you don't have rapid diagnostics in-house, don't make rapid diagnostics the key to your antimicrobial stewardship program, because you're not going to be successful if you set yourself up that way. Maybe even focus smaller yet, unit specific or hospital wide. Where do we need to go? Keep it narrow in scope. Is there a particular consulting group that you might want to focus on? Surgeons do a really bad job of stopping antibiotics. Maybe we pick that one first. But set yourself up for success by picking a single priority area. And then develop policies and guidelines to support that tactic. Educate and publicize. You got to know what's happening. If you don't know what's happening, how are they going to know that that's what they're supposed to do? Implement your activities, monitor and evaluate, and then repeat. And eventually, over time, you now have all 7 activities covered, all 7 areas covered in your antimicrobial stewardship program. It's a lean, mean, efficient machine. And that's what we're really targeting. Use the relationships. And this is my favorite part of having been in small community hospitals. You know who you work alongside. You see them every day. You talk about them. You know their families. You know that the kid just had a t-ball game. You know that they're having a cookout. You know X, Y, Z. Small hospitals have relationships. They are relational at their very nature. Use that to your advantage. It's the opportunity to have open dialogue, honest conversation, evidence-based conversation. And if you convince one provider, that is a significant percentage of who you need to convince. So the critical access hospital I worked at, we had 2 hospitalists, week on, week off, and we had 3 general practitioners that still saw their patients when they came in. So from a general medicine perspective, 5 guys. If I convince one to be on my team with antimicrobial stewardship, that is 20% of medical staff. If I convince 2, I'm at 40%. If I convince 3, it is a landslide runaway victory that I have 60% on my way. And those other 2 are going to get peer pressured into doing the right thing because the other 3 are going to get to bludgeon them on a regular basis. So that's to your advantage, right? This is what we have in small hospitals. Who are you working with? Let's have that conversation. Sometimes it takes time, right? You never walk into the room for the first time and say, here's what you're going to have to do. But hey, what do you like to do? What's going on? What's your experience? It can be a challenge. That same critical access hospital, we had one doctor. No matter what was happening with the patient, he said, oh, just give them vitamin R. Many years ago, Rocephin. Throw some vitamin R at. Honestly, goodness, you could drop 1 gram of Herceptin on everybody who walks through the door, and it just makes you think. So it's not easy, but you have that opportunity. It's not a faceless name that you're just seeing verified orders from on a regular basis. It is somebody that you know, that you can talk to, and you can find. So something we did at Northwestern Medicine to try to get all of our providers to recognize the importance of antimicrobial stewardship is we used this mnemonic called reframe to kind of educate. And so I put it up here mostly just so you can see it as you're having those conversations. So I need to convince my provider, here's a way to have that conversation. Here's a way to get that provider on here. That you can kind of try to reframe their perspective around antimicrobial. To recognize the value and to use them wisely. To execute the appropriate workup of the patient. There's already been lots of talk about overuse of antibiotics and UTIs and not doing the proper workup and assessment. Fight the urge to prescribe antibiotics if it's not likely that they have a bacterial infection. It seems very commonsensical, and yet wide use of antibiotics in situations for viral infection. Resist that unnecessary prescribing. Act together to impact patient care and antibiotic use. Monitor the human microbiome, not C. diff infections, and educate our teams and remind ourselves the value of antimicrobial stewardship. So reframing that conversation and that thinking. All right, work smarter, not harder. I don't like hard work if I don't have to do it. And so how can we make that simpler? So build in some automated processes, things that you don't have to think about, things that your staff doesn't have to worry about. Require the indication on the order. That's a very bare minimum type of thing. What are we trying to treat? Because then when someone else is trying to assess it, they know what guidelines to look at, what doses might be appropriate. Stop dates. Put stop dates on the order. Hard stop dates. I've worked at places that have soft stop dates. They do nothing. They get an annoying little pop-up in 72 hours or 7 days, and you just click one button and they keep on moving. Hard stop dates. I know the pushback will be, but what about that TB patient or HIV or endocarditis? Hey, we'll work through that. Is that the 20% or is that the 80%? Right? Let's figure out what are we really dealing with. We'll put those hard stop dates as a policy, as a protocol, as a hard stop in your AHR. Over time, pharmacy management vancomycin, it's another way that you can build in an automatic process. I'm a big fan of automatic processes, letting pharmacy or nursing automatically do stuff. Can nurses automatically pull urinary caps when the patient no longer needs them? If they can't, we'll talk to our nursing colleagues. What do you guys need? What support do you need? Get those cats out. All right, when possible, use order sets. Order sets are great. You can provide guidance. You can force automatic stops. You can force proper indications. You can put restrictions in place. Some EHRs let you put extra language and clinical decision support. It helps when you do chart reviews. You might be able to run reports and documentation based off that order set. Really nice study was done where they looked and said, we have all of these excellent antimicrobial order sets. They exist, but nobody is using them. So this one hospital, they took a look at it and they found out which order sets were being used. And they found that the general medicine admission order set was used on almost all of their patients. So what did they do? They dropped their antimicrobial order sets inside of the general admission order. And what they saw was an 11-fold increase in the pneumonia order set usage, 47-fold increase in their UTI order set usage, and then 24-fold increase in SSTI. Because doctors were already using it, and they just put the information where the doctors were looking. Work smarter, not harder. You don't have to go and re-educate to find new order sets. You put it where they're already at. And so this is an opportunity. You don't have to, again, create something new. It's already built. Put it where they're going to see it. So clinical decision support. We've already talked about some of the difficulties depending on what EHR you have. Not all EHRs are created equal. Not all will have it. Even then, you need to optimize what you're working with. So back in my CPSI days, Our optimization was we put a whiteboard. Whiteboard was our technology to track who we had to follow, who we were doing based on, who we were doing it. But look at your EHR. Find out how you can find stuff. Can you tag labs to orders? Can you develop order questions? Can you put language in comment fields? Anything you can do to put it in the face of the ordering providers, the administering nurse, and the verifying funds. So optimize. Back to networking. You are not the first person to have to do an antimicrobial stewardship program with CPSI or Meditech or Cerner or Epic. Find sites that are doing it and talk to them. Use ASHP message boards. Use IL, the Illinois pharmacists, use the nursing groups. Just network while you're here. Find out who has the same system you have, what tools are in place, how can we optimize what we're doing. Because looking at reports and patient lists go a long way to help. Someone, we'll talk about it in a little bit, but someone in the other room talked about Century 7. Like, what can you do to put things in front of you? And that's really what we're trying to talk about here, right? How can we know who needs our attention? How can we prioritize what little time we might have? All right, some free resources. And this is one way to get your CFO's ears to perk up real quick, say free. But free resources, students. You have access to students. How can you put them to work? A real question though is, do you have a consistent enough student base to put something on them full time? The answer is no. Still means students are useful. Find out when the students are going to be here and plan your pilot program around that time, because they are labor that you can put to work while also educating on the very important values of antimicrobial stewardship. So there was one long-term acute care facility that looked at students. They did identify a $75 to $64 per day decrease, resulting in $261,000 of real money not being spent over a 2-year period by putting students to work for you. So again, there's the challenge. Do you have enough students coming through? If you're a pharmacist in the building and you have no students, go ahead and cold call those schools of pharmacy. Yeah, you might be down in Carbondale and there's no one close by. Someone might live in the area and be going to school somewhere, and there might be some interest. So put it out there. The worst the school can say is, no, we have enough sites, but they might say, great, we're always looking. Network. Congratulations, you're here at the Illinois Summit on Antimicrobial Stewardship. You have an opportunity to network with people who are doing this day in and day out. Remember, you got 4 or 5 hands in here for a smoothly, efficiently run antimicrobial stewardship program. Again, the Illinois Council of Health Pharmacists, American Society of Health Pharmacists. Just conversation, right? Just talk to people who are doing this, colleagues at any facility, anywhere. What are you doing on antimicrobial stewardship? They might be able to provide something that you have not yet thought of or walk through a challenge. I promised you one more plug, adsp.nm.org, a free resource out there and available for anybody who has the internet to take a look. All right, so some online training programs. These, not all free, but they do exist. They can be ways to help people. They are cheaper than going back to school or doing a fellowship or a residency. So I have done the SIDP pharmacist antimicrobial stewardship certificate. There's the MAD ID, the IDSA has one, and there's one massive open online course. So lots of various ones do exist out there that you might be able to plug people into. Engage other departments. ASP cannot be done in a silo. You have to have physician champions, and they can be across departments of physician champions. So take a look at who you have on your medical stacks at your facility that might be able to be a physician champion. There's no underselling peer-to-peer communication for providers. And so maybe it's a surgeon. Not ever seen it, but maybe it's a surgeon who's like, I don't want to use as many antibiotics. Maybe it's a general practitioner. Maybe it's a pulmonologist. Maybe it's your cancer physician, oncologist. Whoever it might be, get that physician who's on board, who can then go out and talk to the other physicians and try to get them in line. Infection prevention. They manage healthcare acquired conditions. They have a budget. They have the ability to impact policies, protocols, steps. Get them on your team. Laboratory. Again, can't undersell the importance of laboratory. What's the turnaround time on our labs? What's in-house versus send out? Rapid diagnostic testing. We do want to make mention that at Northwestern Medicine, we actually rebranded from ASP to ADSP, diagnostics, because you cannot separate again the value that lab brings to the And that was duplicate. Here we go. Nursing. Any nurses in the room? All right. Thank you for suffering through most of the pharmacy-oriented conversation. You get half a slide, but it is a very, very, very valuable half of a slide. Nurses know more about the patients than anybody else in the building at any given time. They see the patient, they talk to the patient, they have experience with patients that present like this. You don't ever undersell the value of a nurse in an antimicrobial stewardship program. And so some opportunities that exist. There was a survey that went out looking at ways that nurses can be involved in assessing comfort levels. And what they really look for is the nurse can question the need for urine culture. We've already had several topics about that, but the nurse can go, why? That question always ask your physician, why? Proper culture collection, making sure that everything is appropriate and correct. Encourage that transition from IV to PO. Nurses know when the patient can swallow, when they're starting to eat. So they can be very, very valuable in that space. Allergy documentation, hugely important. Make sure that we get that correct penicillin allergy information on the chart. And then assist with an antibiotic timeout. They know when the doctor's round, the doctor comes in. Hey, it's been 3 days since we started this antibiotic. What do you think? Still necessary? Again, face-to-face opportunities for nurses to have that with communication with the physicians. Continuity of care, discharge planning. So discharge prescriptions are huge. I know even at my facility, we often send patients home on 10 days after they've already been on 5 or 6 days. It's an area that we have discharge planning, continuity of care can play a role. How can they help us to prevent readmissions? How can they do good community stewardship? Third-party solutions. So these aren't free, but they might be cheaper than a whole new FTE of people. So is Century 7 or similar pharmacovigilance type things available? Is a tele-ASP program? So can you have someone who lives at a completely different spot do some chart reviews and do some of that antimicrobial stewardship for you? Can you share resources with other facilities in your area? And we don't like to talk with other hospitals sometimes outside our system, but maybe there's opportunity there. How can we partner together? Yeah, you're the next town over, but you're also a small, hired, overworked community hospital. Maybe we can share hired, overworked people to get this done in a correct fashion. Just remember, things are only impossible until they're not. So it seems that way, but suddenly it won't be. I've always been told, don't re-say something if it's already been said better than you can say it. Don't let perfect be the enemy of good. Small steps in antimicrobial stewardship are positive steps. They save you money, they improve patient outcomes, even if it's only one of those areas that we've talked about. Look at your opportunities, plan your way forward, implement your changes, reassess, do it all over again. It never stops. And once you get started on the path, it's not going to stop. Thank you for your time and your attention, and we can open it up for any questions.
Is there any questions? You know, I do have a question.
Yeah.
And it may be like really crystal clear, but I have to ask. So, you know, we rely on antibiotics, right? Antibiotics for the most part have our intravenous meds. But when you want to do a different options for some patients that are admitted, but you know, with this UA frenzy thing. So we talk about it all the time. Somebody comes in with a broken arm and their UA shows something that the doctor says, oh, yeah, you see how you're going to put on those things. Yeah. So we wanted to know, is there any way or any good resource that says if they want to use Roceptin, a person hemodynamically stable, everything's good, they can take oral, they're eating all that great stuff, but the doctor still wants to admit them with this UTI and you can't get them to just discharge them? Yeah. Can we convert to
something suitable. So like some type of
Yeah.
a list of meds that say if the doctor is writing for this, recommend this
100%,
particular
yeah.
cephalosporin. You know, I mean, I understand, you know,
So actually what you're saying is actually something that Northwestern Medicine, we just implemented here in Maine. And so Kish, where I was at, we were using 60 to 70% Procefin on our impaired first drug given on UTIs. In the past month, that has flipped to only about 20% Procefin, 40 or 50% first generation. And so we looked at our antibiogram, we saw cefazolin has 90% covered in E. coli. That tracks on 90% coverage. Why are we using broad spectrum agent for the same level? And so you can use your antibiogram 100% as, for lack of a better term, a weapon
right.
to encourage better antibiotics. So look at what your percentages are, look at what your isolate counts are, look at what your most prevalent bug is. UTI, they're compensating E. coli.
Right.
So if E. coli has little resistance and good coverage to other non-third generation cephalosporin, that's the conversation. That is what.
And that's what I was thinking. I just didn't know if there was some resource out there that said, hey, this is what we've been doing.
So they probably are. I think we put that on ADSP. .NA.org. So pop there, check resources, UTI initiative. I might be on this list here. And actually talking points in here, just laying out.
Oh,